ahead and probably get started. Thank you for going ahead and starting the recording. So just as a heads up for everyone, we will go ahead and be recording this meeting and also posting it on our website so that folks can go ahead and watch afterwards. And with that said, we want to go ahead and welcome everyone for joining today's session titled Be a Vaccine Hero, How Public Health Professionals Can Address Vaccine Hesitancy in the South Asian Community. This event is organized by the Advocacy Community, a committee of SAFA, or the South Asian Public Health Association. For those who may be new to SAFA, we are a national organization that brings together professionals dedicated to improving public health outcomes for South Asian communities across the U.S. My name is Niharika Rane, and alongside Shashraya J, we'll be co-presenting today on behalf of SAFA's Advocacy Committee, which is hosting this particular event. The Advocacy Committee, where we focus on health communication and education, also addresses misinformation within the diaspora community. We'd also like to acknowledge our committee chairs, Anmol and Nawal, who are with us today in the audience. They'll be monitoring the chat, so if you have any questions, comments, or tech issues, please feel free to go ahead and let them know. Also, before we get started, we'd love to get to know a little bit more about you all. So if you haven't already, please take a chance to introduce yourself in the chat. All right, thank you all, and let's go ahead and get started. All right, so also we do want to go ahead and go over a brief agenda. We'll go ahead and start with a brief introduction about SAFA, followed by our workshop intentions and guidelines. Next, we'll share SAFA's land and labor acknowledgement, host a quick icebreaker, and then fill out a short pre-survey before introducing our wonderful speaker, Baldeep, who will lead a very engaging presentation and activity. We'll wrap this up with a Q&A session, so please keep your questions and reflections coming in the chat throughout. We'll go ahead and address them after the presentation ends. All right. And so with that, let's go ahead and get started with our SAFA introduction. SAFA is the leading voice on public health issues impacting South Asians in the United States since 1999. Our mission is to promote the health and well-being of South Asian communities in the U.S. through advocacy, collaboration, and communication. These three pillars really guide all of SAFA's work, including today's workshop. To carry out that mission, SAFA focuses on three key goals. First, to advocate for South Asians on priorities that impact health, from chronic disease to vaccine access. Second, to foster partnerships and collaborations with other organizations, professionals, and community stakeholders. And third, to communicate current and relevant research, data, and knowledge gaps. For more information, please visit us at safa.org. Before we dive deeper into our main discussion, we'd like to take a moment to set some intentions and agreements for a time together today. First and foremost, we invite everyone to try their best to be present while also being responsive to your own needs. If you need to take a sip of water or stretch, feel free to do so. We also ask that we respect everyone's pronouns and remain mindful of our assumptions around others' identities. And third, we want to center learning, curiosity, and growth. We're here to explore, question, and learn together. And finally, please engage in whatever way feels most comfortable to you. Every question or activity is an invitation and not a requirement, so you can always say no or maybe later. We also want to invite you all to review this land and labor acknowledgement and read on your own time. But essentially at SAFA, we recognize that the work that we do, the people that we serve, and the institutions that we work in all have been built upon the backs of forced labor and enslavement of those of African descent, as well as on the stolen land of Indigenous communities. And so before we do the work that we must also acknowledge this legacy and how it impacts public health and justice today. With that said, let's go ahead and join on Menti for a quick icebreaker. Please go ahead and scan this QR code, or we can also join with this link. Nawal, I'm not sure if we can drop this link in the chat as well, so it's easy for folks to join in on. And I'm just going to give folks a couple of minutes to join on Menti, and I'll go ahead and stop sharing my presentation and scooch over to Menti shortly as well.
Oh, you're on mute.
Yep. Can everyone hear me okay? Wonderful. Thank you so much, Naharika, for getting us through the icebreaker and just setting the stage. My name is Sashraya. I'm one of the interns on the NCAPA Racial Equity grant within the research committee at SAFA. And so today, before we move into our speaker's wonderful presentation, I just wanted to start off with a little bit about the history of vaccine hesitancy within our community so we can all have a better context for why our communities experience distrust. So for this example, we're going to be using smallpox as a case study. And even before vaccinations, variolation was the major method prior to vaccines being invented, where infectious matter was purposefully applied or inhaled to prevent infection. And this was practiced widely with high levels of acceptance in the region. However, like with other examples in history, during the period of British colonization, the indigenous were actually blamed for the spread of the disease despite their best efforts to prevent it with the knowledge that they had had. And eventually, the smallpox vaccine was discovered in 1798 based off of practices of variolation in South Asia, but from other regions of the world as well. With the vaccine eventually arriving in India in 1802, there was a strong push for vaccination over variolation, demonstrating the colonization of indigenous practices by British forces. The 1892 Compulsory Vaccination Act was met with resistance despite an ongoing epidemic due to financial, cultural, and religious perspectives, but as well as general mistrust with the British rule and the violence that they had inflicted to our people for so many years at that point. Further efforts failed to effectively disseminate the vaccine across the country as well and the region, resulting in varied vaccination rates. And this is an issue that we still see today, especially with COVID. As of 2025, a triumph in vaccine efforts was seen, with childhood vaccinations in South Asia being the highest that they had been, according to the World Health Organization. However, when we see the distribution of the COVID-19 vaccine, it really highlights an issue of how there's an inequitable access across South Asian ethnicities, especially when compared to white communities as well. So, thus, the vaccine hesitancy and decreased access still present a critical issue, and we must continue working to dismantle this hesitancy and increase education in our communities. Next slide, please. And so I kind of want to bring it back to our current landscape. Of course, vaccines have really been in the news a lot the past few months. And beginning with some SAFA studies that we had done earlier this summer, the research committee worked on a South Asian misinformation landscape report. And these topics included chronic disease, reproductive health, and vaccine hesitancy. One of our interns conducted a media analysis and we wanted to assess the presence of misinformation, attitudes towards vaccines, with an overall goal of better understanding what vaccine hesitancy looks like in our community. And so results found that there were moderate levels of misinformation with a higher frequency of negative sentiments towards vaccines versus positive. 22% of these results demonstrated deliberate disinformation, so with the intent to spread harmful information, while approximately 8% were misleading but not intentionally deceptive, kind of alluding to the fact of maybe incorrect education and just not knowing where to get sources from. Um, However, once we shift focus to the current vaccine landscape in the US, as we have seen in media, vaccines have been a very big hot topic, especially within our current administration, and leading to a lot of confusion and chaos across the nation for both patients but also providers. And this just feeds into that growing distrust in national regulatory boards and fractures an evidence-based vaccine schedule as well. Recently, ACIP, or the Advisory Committee on Immunization Processes, voted to not require a prescription for the COVID vaccine after previously there being a statement that you would need a prescription. Um, and so they did retract that initial statement and voted to increase access and still ensure insurance coverage. While the state of Florida has been making headlines for not requiring state required vaccine schedules for public schools and other environments as well. One sec. And so this lack of national alignment on vaccines really influences the public trust in vaccine safety, efficacy, and other public health institutions in our country as well. Next slide, please. And so we have some examples here actually from that media analysis that our team conducted earlier this summer. And I just wanted to touch on a few of them. So these are all pulled from X or formerly Twitter and demonstrate views of individuals from the South Asian community. Example one is talking about the COVID vaccine and is discussing how it is a poison that was distributed by the government, while example three creates stigma around the HPV vaccine, which we do kind of see in high rates within our community as well. But you can please take a moment just to kind of brief over these other examples that we have listed. And next slide. Thank you. And now I would like to introduce our wonderful speaker for tonight, Dr. Baldeep Dhaliwal. Baldeep recently graduated with her PhD in International Public Health and International Health from Johns Hopkins University and is currently appointed as a postdoctoral fellow for the Berman Institute Oxford Joint Program in Global Infectious Disease Ethics. Her primary focus has been studying and researching vaccine hesitancy and building vaccine confidence during the COVID pandemic in Haryana, India. And she has led numerous advocacy efforts for vaccine policy and values community driven decisions to build capacity and sustainable strategies. Some of her notable publications include Vaccine Acceptance in Rural India, Engaging Faith Leaders as Vaccine Ambassadors, Community Perceptions of Vaccination Among Influential Stakeholders, Qualitative Research in Rural India, and Leading from the Front Lines, Community-Oriented Approaches for Strengthening Vaccine Delivery and Acceptance. So without further ado, I'm excited to hand over this next half to Baldeep for the great presentation and activities she's developed for us.
Great, thank you so much. I'll go ahead and share my screen. Okay, great. So, hi everybody. Thank you so much for that very generous introduction. My name is Dr. Baldeep Dhaliwal, and I'm here to talk about vaccine hesitancy in the South Asian community. So before diving into my talk, I just want to share a little bit about my own journey and how it brought me to focus on vaccine hesitancy. So I began with a master's in health policy and management, and I intended to work on domestic health policy. And after a few years of doing that, I wanted to return to research to ask bigger questions focused on health systems and having a specific focus on vaccines. That led me to the International Vaccine Access Center, where I worked on strengthening vaccine access through community engaged strategies. I then began my PhD in international health. My dissertation research focused on health systems, while I also worked on vaccine advocacy in countries that were facing humanitarian crises like Somalia. These experiences in crisis settings reinforced for me that vaccine hesitancy is not just about individual attitudes, but about broader issues that we need to be aware of. And today I'm affiliated with the Berman Institute of Bioethics, where I study at the intersection of ethics and infectious disease. And I also serve as adjunct faculty at Towson University, where I teach health communication. So across my roles, I've focused on how we can respond to vaccine hesitancy in ways that are ethical, context specific, and grounded in reality. The most important thing to know is that vaccine hesitancy is not a singular problem with a simple solution. It emerges across individual, community, and system levels. To explain that a bit more, I want to start with a story about vaccine hesitancy. In August 2021, two friends in rural India, Sunitha and Arti, were both 9 months pregnant. Between them, they already had 5 children. Neither Sunitha nor Arti nor any of their children had ever received a single vaccine. When community health workers like the one in this picture used to come to their home, the family would refuse vaccines. They would say, "Nothing has happened to us till now. Our children are fine. Why should we get vaccinated?" Sunitha and Arti would show the community health worker videos from WhatsApp about how vaccines could cause infertility. Even though the community health worker assured them that that wasn't true and that the health system was trying to protect kids from diseases, they were still very hesitant. When Arti heard this about the health system trying to protect them, she asked a heartbreaking question. She said, "Why should we trust a health system that hasn't even given our children birth certificates?" This question shows that refusing vaccines isn't just about fear of side effects or being nervous. It's about neglect, mistrust, and feeling ignored by a health system. Over several visits, our project team showed Sunitha and Arti pamphlets with local respected champions. We met with religious leaders to answer local concerns, answer their questions, and get their support for vaccines. And eventually, some of these religious leaders became advocates for vaccines themselves, so we were able to share on WhatsApp and counter misinformation that they were seeing on WhatsApp. Slowly, Sunitha and Arti shifted, and both women accepted the TD vaccine to protect themselves and their babies. It was a very small step, but to see this as a success story was transformational for me as a vaccine advocate and as a researcher. I'm sharing this story because it reminds us that vaccine hesitancy is never just about being nervous. It's about structural neglect, access barriers, intergenerational experiences, and above all, trust. This is as true in rural India as it is in the diaspora communities here in the United States. So today I'm going to explain how these dynamics shape vaccine advocacy for South Asians abroad and what we can do about it. South Asians are one of the fastest growing immigrant groups in North America, as well as in many other parts of the world, as you can see by the countries marked in yellow. These populations have left South Asia and made their homes in other pockets of the world, and they make up the South Asian diaspora. The South Asian diaspora is incredibly diverse. We come from different faiths, we speak different languages, and we have unique migration stories, but we also share common challenges when it comes to health access and trust in institutions. There are several components that contribute to hesitancy in the South Asian diaspora, which I'm going to go over, and I'll also give strategies for overcoming each of these issues. I want to start with some historical roots, kind of building off what was said, and the intergenerational trauma that this may have caused for populations. In the 1960s and 70s, the WHO and Indian health authorities launched the smallpox eradication program. And on paper, it seemed like a classic public health program. There was surveillance, there was mobilization, there was isolation, and vaccination and by force when necessary. And for many communities in India, the campaign was seen as an intrusion on their bodies, on their beliefs, and on their autonomy. People across India resisted the campaign strongly because they didn't want to be forced to be vaccinated against smallpox. Some people refused to let vaccinators enter their homes, and others hid infected people from the vaccinators. Others simply said no because they felt like the British was making them take this vaccine against their will. In this very violent case described here, a vaccinator team broke down doors in the middle of the night and they forcibly vaccinated a tribal family against smallpox. In this case study, a tribal man named Mohan Singh said that it was his moral duty to resist. He was insistent that he did not need to be vaccinated. He said disease and life are in God's hands, and he doesn't want needles imposed on his family. This may feel like it was a long time ago, but this was in 1975. That may be within your generation, or if not, it's almost certainly within your parents' generation. This history matters because we see the same tensions in vaccine debates today. We see a lack of trust. We see people who feel like they're being forced to get vaccines. And we see people who feel like their voices are being completely ignored when they have simple questions. When communities feel that something is being done to them rather than with them, resistance makes sense. When people are being treated with respect, like these women who were brought in to advocate for the smallpox vaccine, they can be swayed and maybe even turned into advocates themselves. It's important to be aware of this history because these stories, like Mohan Singh's, did not stay in India. Many South Asian diaspora communities are just one generation removed from campaigns like this. So these memories have been shared in families and they've started some of the mistrust that we see in public health today. This is why vaccine advocacy cannot afford to repeat the mistakes of alienation. We need to focus on being grounded in partnership, in cultural sensitivity, and in community trust. When we talk about hesitancy, we also can't just blame people being confused or people not knowing what's going on. We need to think about the systems that have made it difficult for people to get vaccinated, and we have to think about how we can overcome those barriers. So let's start with structural barriers. These are the things that make it harder for people to get vaccinated even when they want to. For many South Asian immigrants, language access is one of the biggest challenges. Vaccine clinics often only provide English or maybe Spanish information, leaving out other speakers. So some of the South Asian diaspora might not be able to fully understand the text messages or emails that they get about vaccine schedules in English, so they might miss vaccines because of that. Work schedules also matter. A large part of the diaspora works in shift jobs at gas stations, trucking, food service, where taking time off during the day to get a vaccine isn't possible or isn't financially possible. Transportation is another barrier. Vaccination sites may not be located where South Asian communities live, and if you're relying on buses or ride shares, that could mean hours of travel. In a small study on hesitancy among South Asians in New York City during the COVID campaign, people were simply not able to get to the site and they weren't in a position to take time off work to take several buses to get there. So many South Asians weren't able to get the COVID vaccine. And finally, cost is a structural barrier. While most vaccines are technically free, many families worry about hidden costs like losing hours at work, having to pay for an Uber, or even medical bills if they have side effects that they weren't expecting. So, to summarize, structural barriers are not about fear or misinformation, they're about access and equity. So this slide highlights some of the practical solutions that can help overcome structural barriers to vaccination. For language barriers, it's about meeting people in the languages that they actually use through multilingual flyers, interpreters at clinics, community radio, or even WhatsApp voice messages or group messages. When clinic hours don't align with people's shift work, that means that extending hours into evenings or weekends might be beneficial for those populations, or organizing workplace vaccination drives so that workers can still access vaccines. Transportation challenges can also be reduced by bringing services closer to people with pop-up clinics at familiar and trusted community hubs. And finally, when people are worried about costs, the key is clear communication that vaccines are free. Another thought is pairing drives with free health checkups or cultural events can further build trust and encourage turnout because that provides them with a service that they actually need as well. So these solutions all focus on one core principle, which is making vaccines accessible by removing the barriers that stand in people's way. Another powerful strategy for increasing vaccine uptake and overcoming structural barriers, especially right now, is aligning outreach with cultural and religious holidays. These holidays can be strategic touchpoints for public health because during festivals, communities are already coming together. These gatherings create opportunities to reach people with health messages, especially for seasonal flu and COVID shots. So, for example, setting up vaccine booths at temples during these events can make access convenient and visible and make people feel more confident in getting vaccines. It's also a time generally when people are thinking about health and family and well being. So, linking vaccine messages to these values that are aligned with these cultural holidays, like protecting loved ones or having a healthy start to the season, can make them resonate more deeply. So, thinking about how to align vaccine messages with cultural messages is a really overlooked strategy. So, now I want to highlight a real life example of how people leveraged cultural settings for vaccine advocacy. So, as I'm sure everyone remembers, in early 2021, there was a big movement to reach people at any location to get the initial doses of the COVID vaccine. So, in this example, there was a pop up clinic at a local temple in Washington state where they tried to overcome many of the structural barriers that people face. To start, this campaign focused on language barriers, and they brought in people who were fluent in 14 different languages. Having this many translators helped people ask questions about side effects, insurance, or anything else in a language that they actually understood. They also met people where they were in terms of hours. So from this example that I have here, the two women who are in this example weren't able to get vaccines during standard pharmacy hours because of their work schedules. They were both working 6 days a week, about 65 hours a week, and the only day they had free was Sunday. So by having the clinic on a day that shift workers were largely free and by having it at a location that they were already at helped ensure that they were able to get the vaccine. So this is a really good example of making sure that we're meeting people where they are in order to provide vaccination services. So when thinking about the structural barriers I laid out earlier, in this example, the campaign worked to address all of these structural barriers. They had translators, they aligned with the work hours, they picked a place that people could easily get to and one that most of the target population was already at on Sunday, and they provided vaccines free of cost. Next, I want to focus on misinformation. So that is the type of misinformation that we see about vaccines and also how to overcome that misinformation. So I want to begin by acknowledging that misinformation does not just appear randomly and it doesn't just stay in one group chat. A rumor that starts in a WhatsApp chat in India can show up on someone's phone in California within a couple hours. Misinformation spread on social media is also especially dangerous because it's often personal. It's forwarded from a family friend or a trusted person, and it's hard to know what to believe when you're getting a message that comes from someone you personally know. The American diaspora is also in a really unique situation. We are hyper exposed to misinformation that's already circulating in traditional American networks like Twitter and TikTok, or X and TikTok. But we're also exposed to even more misinformation because we're so reliant on WhatsApp messaging to keep us connected to South Asia. Thinking about WhatsApp specifically, India is the largest global market for WhatsApp, with hundreds of millions of users using it every single day. And with that reach comes a major challenge. Misinformation can spread just as quickly, if not faster, than accurate information. And we see this play out in three key areas. So, politically, WhatsApp has been used to circulate false claims about elections. Religiously, it's fueled rumors that have led to retaliation and violence between communities. And in public health, misinformation about vaccines has spread widely. That's everything from false side effects to conspiracy theories. These rumors directly shape trust, decision making, and people safety. We often think about rumors as being like the ones that are here on the screen about COVID, like COVID's a weapon from China or homeopathy prevents COVID, neither of which are true. But these rumors are not new. Rumors about vaccines have been around for a long time. This article in the top corner was about a routine campaign for the measles and rubella vaccine in 2017 that was completely derailed because of rumors that were spreading on WhatsApp. And when we look at the type of misinformation that circulates in South Asian communities, there are three broad patterns that emerge. First, misinformation that creates community divisions. So these are rumors that cast vaccines as being foreign products, as being unsafe, or they're being framed as designed to harm particular groups. So, for example, during COVID, there were a lot of WhatsApp messages about how certain religious groups were being targeted with harmful vaccines and people in other religious groups were getting the good vaccines, which isn't true, but it created a lot of hesitancy. Second, misinformation that promotes alternative remedies like homeopathy. These messages often feel like they're from our culture and they're grounded in our roots, but they discourage vaccination and they are not rooted in reality. So, for example, in early 2020, a government press release came out to encourage people to consume supplements, including one that could be deadly to people. So, this was the official communication from the government, and this was highly concerning because they presented many of these supplements as prevention strategies, but there wasn't evidence to suggest that they would have been effective. Further, one of the supplements that they suggested was arsenicum album 30C, and it's usually non toxic because it's supposed to be dilated. But if it's not correctly prepared, it can be deadly and it can be very, very, very dangerous to people. And third, misinformation can often be rooted in stigma and shame. And this usually targets vaccines that intersect with issues of gender, sexuality, or morality. And we'll dive into this more in the next section when we talk about HPV. But together, these narratives show us that misinformation is not random. It taps into identities, taps into fears and traditions that are deeply embedded in community lives. So how can we overcome it? There's a couple different strategies that I'm going to talk about here. So one approach is to work with community champions, and who your champion is will really depend on your community. So in this first study, they looked at endorsement from different religious leaders and saw that it only made an impact in one country. So this might work very well if you're in a particularly devout area, but if you're not, it might not be the best strategy. Another idea is to use something simple, like the flyer in the middle. And this is usually most successful when you can collaborate with someone in the community that people already know and they already respect. And lastly, barbers and stylists were really effective vaccine communicators during the COVID vaccine campaign among Black communities in Maryland. So that is another strategy of trying to find someone who might not be a traditional champion and having them work with you. So these are all really different champions, and what you need to remember is thinking about who your audience is. So what works for a 50-year-old, very religious person probably won't work for their 20-year-old son. We need to make sure that we meet people where they are, and we need to tailor our strategies to that audience. So, two, videos as a counter to misinformation. So, another strategy that works particularly well on WhatsApp is short videos or voice notes in local languages. So, think of a 60-second clip in a local language by a trusted individual that explains the facts in normal day-to-day language. So in this study I have on the screen, researchers saw that about 25% of all misinformation across South Asian WhatsApp networks were just inaccurate videos. And videos are especially scary sources of misinformation because they use scientific language, they say they have credible sources, and they appeal to this idea of community solidarity. Making a counter video that can be disseminated on WhatsApp is so effective because this mirrors the format of misinformation. It's short, it's shareable, and it's informal, just like the misinformation videos. But instead of spreading inaccurate information or spreading fear, the video can be used to spread clarity. And because it's in the right language and it's from the right messenger, people are much more likely to continue to forward this on to their relatives and their friends. Another strategy to overcome misinformation is to work with youth like they did in this study. So in this study, the research team in Toronto partnered with South Asian youth to collaborate on improving vaccination. And after implementing this intervention, almost 52% of the youth reported that they were able to sway someone in their community to get a vaccine. This is a huge statistic and definitely a way that might make an impact in the community. Often, young people in diaspora families are already playing an important role. They're translating reliable information and they're translating that information to their parents or grandparents or even to extended members of their family. So, this is a way to tap into that existing dynamic that already exists. So, lastly, I want to focus on stigma. Stigma and shame is something that is consistently used to spread misinformation messages as well, and I'll break down how this happens. So, stigma and shame tend to be used in misinformation campaigns, which end up contributing to vaccine hesitancy. So, a very common example is the HPV vaccine. Because it's linked to cervical cancer, raising the subject may feel a little bit taboo in the diaspora. But ignoring this vaccine creates space for the rumors like the one I have on this slide, which are not accurate. And when we can't talk about vaccines openly without stigma and without shame, misinformation will fill that silence. So in this final section, I want to explain how to counter this using a great resource called HPV IQ. HPV IQ is a website that's designed by UNC Chapel Hill researchers, and this website has materials that promote creating safe spaces for dialogue and empowering trusted voices and healthcare providers to break myths around the HPV vaccine. This, of course, is geared towards HPV, but I still think the lessons from this are very transferable to other vaccines. So one tool that they've provided on their website that I want to highlight is the announcement approach. It's a 3-step process that starts with a presumptive announcement that assumes parents are ready to vaccinate. So this is an effective way to recommend adolescent vaccines, including the HPV vaccine. So here's an example of how a provider could frame this. You could say, your child is 9 today, so it's time for their vaccine. Instead of phrasing it as more of a question, just assume that they're ready to accept the vaccine. If they're concerned about vaccine safety, here's an example of a response that a provider could give to make them feel more confident, explaining that there have been over 100 studies on just the safety of HPV vaccines, and they have consistently found that it's really safe, just like all other vaccines given to children. And lastly, if they're still hesitant, it's important to try again later. And make sure you let them know that you'll try again later. Say you're going to bring up the HPV vaccine at the next visit, and then make a note in the child's chart to do that. Almost 70% of people who initially decline the HPV vaccine later agree to it. So it's really important to try again. These are some effective quotes that are recommended to use when talking to parents based on their specific concerns. So if they're concerned about safety or guidelines or age, there are some suggested quotes on how you can respond to that. In the last couple minutes of my section of the presentation, I want to highlight a project that I led in 2020, and I want to show how when you try to address multiple elements of vaccine hesitancy, you really can overcome the true barriers. So I designed a project in 2020 that worked with community leaders, religious leaders, and community health workers to identify barriers to vaccines. I talked to people about strategies to overcome these barriers and ultimately implemented the strategies that would work best for the needs of the community. To do this, we used human-centered design, where we had meetings and workshops to co-design solutions. And this is where we actually just listened to people tell us what they needed to overcome vaccine hesitancy. After that, we co-designed this intervention to strengthen vaccine uptake, and we tried to tackle all the key elements of structural barriers that I flagged earlier. Oops. For language and cost barriers, we had videos of local leaders in the local dialect talking about the benefits of vaccines. We also made up pamphlets that were largely made up of pictures and very basic words, and these pamphlets had people advocating for vaccines and explaining that they were free. For transportation and work schedules, we collaborated with people in the health system to ensure that all vaccines were being offered at times that worked well for people in that community. So we prioritized making sure that this consistent visit schedule didn't conflict with times that parents would be working at home or they would be out in the fields. And then to address the rumors in the community, we worked with local religious leaders. We met them to find out what their concerns were. We addressed their concerns, and then we built trust with them over time, and they got involved in helping us dispel the common myths about vaccines. So after the intervention, parents reported feeling much more confident about vaccines. The quote from the parent in the bottom part of the screen described how seeing a pamphlet from the local teacher helped sway them to get vaccines. In the upper corner, community health workers and leaders noted that they felt more equipped to counter misinformation. When they showed WhatsApp videos, especially to people, members of the community were very quick to accept the vaccine because it was from a trusted person that they already knew. This image is mostly just for reference. It just explains how we did this project, but I want to emphasize that when you apply local voices to address local needs, it can help overcome vaccine hesitancy. So there may be solutions that worked great in India that wouldn't necessarily work in a diaspora community, but the five-pronged approach that we took that I just described worked incredibly well for the community that I was working in. It was a very religious community. They were skeptical of outsiders, and they didn't want to see vaccine champions who were people like cricket players. They wanted to see their local leaders and heroes. So, for diaspora advocacy, applying some of this same strategy of finding out the barriers and finding out what people are worried about can help you design solutions that will work well for the community you're trying to help. So, when you're thinking about how to overcome vaccine hesitancy, it's important to know what community concerns are, how people want messages presented to them, and to treat hesitancy as a multi pronged issue and not with the mindset that people just don't know. To close, I want to remind everyone about how we began our discussion today. So, we started with a story of how our cultural history of resistance during the smallpox campaign and of families who carried that mistrust impact the way that we look at vaccines today and impact the way we look at the health system today. These histories matter because they continue to echo in diaspora communities. We've seen how vaccine hesitancy is never just fear or just being nervous or just not understanding. It's shaped by structural barriers, it's fueled by misinformation, and it's deepened by stigma and shame. But we've also seen that these challenges are something that we can overcome. We can make community driven videos in local languages. We can host vaccination drives at religious spaces. We can bring in youth advocates to translate information for their parents. We can break the silence around stigma. These are the building blocks of advocacy. When we combine access with trust and move closer to communities, then they feel seen, respected, and protected. Vaccine advocacy in South Asian populations, whether in Washington, D.C. or in California, have to be built with and not for the people we serve. So thank you so much for your attention. I am happy to answer any questions now or after the activity, but I'll go ahead and stop sharing my screen.
It was a wonderful presentation. It was very timely, like Nawal said, so we really appreciate your time on this topic. And so with that said, we do have a post survey. This is to get all of your feedback to see how the event went and what we can do to improve. We will drop the link in the chat and we will also put it in the post workshop email that we will send out. But in the meantime, we do want to go ahead and share some resources. So our wonderful speaker has provided some suggested readings for all of our attendees that are on the right side of this slide. We will also go ahead and share this in our post-workshop email. It will actually be included in a guidebook that we will be providing. This is a 4-page guide that we have created. The first 3 pages are for public health practitioners. And so it goes through some of the toolkit details that will be provided and explained upon. And then the last page is actually a myth buster with some common myths that are circulating within the South Asian diaspora. So we hope that you will all find this useful, and then feel free to provide any feedback as well. And so with that said, we do also want to highlight some other recent toolkits that we have recently published. So the first is SAFA's Misinformation Toolkit, which Shreya just went ahead and provided some details upon when she was giving her history debrief for vaccine hesitancy in the South Asian community. We also have a caste-based discrimination toolkit and mental health toolkit that are all published on our website. And we recently had an economic empowerment workshop as well. The recording for this is again on our website. So we hope that you will all take some time to go ahead and read into all of these, and again, provide feedback if you all found this useful. One other exciting update that we have is that we have a SAFA Gala and conference coming up in November of this year. This is a chance to go ahead and meet and connect with other like-minded South Asian public health practitioners and have important conversations on public health topics of the day. We'd love for you all to join, and more details on how to go ahead and register and join will be shared in the post-workshop email. And then, of course, details can be found on the website as well. And so with that said, thank you all for attending this workshop. We have some avenues to connect with us listed here. But with that said, any other last minute questions or comments would also be appreciated at this time. All right, so I see that Noel has kind of dropped in the references and resources for the vaccine advocacy one-pager, or the toolkit, sorry, in the chat as well. And then Shreya has the Google form for post workshop survey as well in the chats. All right, so again, thank you all for attending. We'll go ahead and have you all hopefully have a wonderful evening ahead if you're based in the East Coast, or a late afternoon if you're in Pacific time like myself.